disease. So the goal is of this medication class is by increasing the acetylcholine levels, cholinesterase inhibitors help improve cognitive symptoms in patients with Alzheimer's disease. So what does PGX have to do with cholinesterase inhibitors? Well, the metabolism of cholinesterase inhibitors involves enzymes like your cytochrome P450, specifically 2D6 and 3A4. So genetic variations in these enzymes can influence the metabolism and efficacy of these very famous drug class cholinesterase inhibitors. So individuals who are poor metabolizers of cytochrome P2D6 may have a higher drug concentration and increased risk of adverse effects from these cholinesterase inhibitors. So that's a very major drug class that's impacted by pharmacogenomics. Another key drug class is your famous NMDA receptor antagonists, such as memantine. Just as you can recall, or maybe you don't, I'll just quickly remind you what it does. Memantine targets the glutamate system in your brain. You don't remember, I'll again review with you quickly. Glutamate is the excitatory neurotransmitter, it's the opposite of GABA, right? So glutamate is excitatory neurotransmitter involved in synaptic transmission and memory formation. Now, in Alzheimer's disease patients, excessive glutamate activity can lead to the neuronal damage and cognitive decline. So the goal of these medications is that these NMDA receptor antagonists, they block the NMDA receptors to help regulate the glutamate levels and protect against excitotoxicity in the brain. So glutamate is great. Too much of it can be very, very toxic, and that's what we're trying to manage. So when it comes to pharmacogenomics, the metabolism of memantine is mediated primarily by renal excretion with minimal hepatic metabolism. However, genetic variations, though, have been noted in drug transporters or receptors involved in the renal excretion of memantine that can eventually impact the drug levels and response in the patients. So that's where pharmacogenetic testing comes in. It identifies the genetic factors that is the excretion or the clearance of memantine, allowing for more personalized dosing regimens in Alzheimer's disease patients. I hope that made sense. I'll
Please,
definitely answer any questions.
sorry. Please, Esther, can you mute yourself, please? Esther Onwobulu, please, can you mute yourself? Thank you.
And again, if you have any questions, it's not very clear, I'll be happy to clarify them at the end of our session today. Okay, psychiatry and PGX. I think someone's not muted. Perfect, thank you. So there have been offering new insights and tailored treatments in psychiatric medication, specifically for individuals struggling with mental health conditions. So as you all know, antipsychotic medications play a crucial role in managing these disorders like schizophrenia, bipolar, and major depressive disorders. However, the response to these medications can vary widely among patients. So with some individuals experiencing significant benefits, and then you have others that encounter significant adverse effects or minimal improvements in their condition. So the goal is that through using pharmacogenetic testing as a tool in psychiatry, it'll help optimize treatment decisions because we'll be able to better understand any genetic variances that are influencing drug metabolism, efficacy, and adverse reactions. When it comes to psychiatric medications, the most common drug metabolizing enzymes that are relevant to this condition are the cytochrome P2D6 and 2C19. And that's what we know so far, but there's so much more that we still want to delve into. Okay. So that's about psychiatrists' general overviews. Now, infectious diseases is one of my favorite because it not only studies the genetics of the patient or the host, but they're also recently been opening a new discipline about pathogen genomics, where they're studying the DNA of the virus or the infection it's of the virus or the antibiotic, not antibiotic, excuse me, the viroid or the actual bug itself. So it's very unique and it's a very new discipline. Then there's so much more that we need to cover and discuss. But the idea is that through pathogen genomics, allows us to better select more appropriate antimicrobial therapy and dosing, specifically in antiretroviral drugs and HIV treatment. Genetic factors also influence the susceptibility and the response to infectious diseases, like all these other conditions we talked about earlier, and it helps predict and prevent severe adverse reactions to antibiotics. So again, it's a huge, huge discipline. There's so much more that we need to cover, but it's just exciting to see that they're going into the pathogen genomics as hopefully a speck of hope that we may be able to control infectious diseases better. Now, pain management, huge, huge. We all know the major issue with pain management, how difficult it is, especially when it comes to opioids because of their addictive nature. So, when it comes to pain, a few things I want you to keep in mind. One, we talked about this earlier about the use of codeine and how codeine is a prodrug that needs to be metabolized to morphine. So, if they have different metabolic rates and different pathways when it comes to 2D6 metabolisms, that will impact their response to the drug and how quickly they metabolize it and they clear it from their system. So, those are just one example. In general, genetic variations do affect even pain perception. People have different perceptions of pain and also how they react to drugs. So the goal is through PGX, we can better tailor the dosing and the selection of these opioids and hopefully to reduce the adverse effects of a lot of these medications. And again, like you know, pain medications, it's complicated. The nature of pain in general is very complicated and involves a multifactorial drug response. So there is so much potential. There's so much more that we need to talk about and we need to research when it comes to pain management and reducing opioid risks in general when it comes to our patient populations. Transplant medications. That's another big area that we're also using pharmacogenomics in. We have a few key medications. I'm not sure if you're familiar with them. Calcineurin inhibitors, such as tacrolimus or cyclosporin. Those are cornerstone medications used in post-transplant immunosuppression to prevent organ rejection. Now, these medications, the problem with them, they have a very narrow therapeutic index, and individual responses can vary significantly. So genetic variations in their gene metabolizing enzymes like your 3A4, 3A5 can really influence the metabolism of your calcineurin inhibitors, and that can lead to varying drug levels and efficacy. And it's dangerous because of its very narrow therapeutic index. So the goal is pharmacotesting should be used to help identify patients that are at risk of overexposure or underexposure to these medications. A second key drug that's used in transplant is azathioprine. I'm not sure if you know that or in your country, but it is another immunosuppressive medication commonly used in transplant recipients. Genetic variations in the TPMT gene can impact the metabolism of azathioprine, and that leads to the variation in the drug efficacy and toxicity. So individuals with that reduced TPMT enzyme activity may be at increased risk of myelosuppressive or other adverse effects. So the goal is that with the pharmacogenetic testing, we can better guide dosing strategies and reduce the risk of complications. And last but not least, a third very common drug class used in transplant patients is mycophenolate mofetil. Proliferation. It's completely useless. So here's the problem. Genetic variations in enzymes involved in the metabolism of the MMF to its active form, such as UGT1A9, can influence the drug exposure and response. So the goal is to see who may have that genetic variance and may require dose adjustments before they deal with these adverse events unnecessarily. And that would help with optimal immunosuppression and minimize all those GI side effects associated with the MMF therapy. Okay? And lastly, rare diseases. It's a big deal to use pharmacogenomics because not that many people have these conditions. PGX is critical in helping us better understand how to treat these diseases. And the goal again is to guide the development and the use of new orphan drugs. In addition, to identify potential repurposing opportunities for existing drugs, maybe we can use drugs that that are being used for other conditions for these rare diseases if we better understand the mechanism and the genetic changes that are taking place in these patients that are manifesting these signs and symptoms. So the challenge is though is that the problem with any rare disease, I'm sure people that have gone through or have managed clinical trials, is that they include a very small patient population. So it's very hard to find the right number for developing clinical trials and getting that percentage that will provide clinical evidence significant to make it significant outcomes. So that's the only problem with rare diseases. But I mean, there's definitely hope when it comes to pharmacogenomics in this specific population. So, what are the challenges? What makes pharmacogenomics a little bit more difficult in implementing than any other like basic lab tests, like your A1C blood draws or your hypertension testing? What makes this a little bit more complicated? Well, here's the thing. When it comes to pharmacogenomics, the first key element is for you to understand the intricate interplay between our genes and the environment, like I discussed during our time about epigenetics. Here is the situation. Environmental factors play a crucial role in influencing the expression and the replication of genes. Factors like your diet, your lifestyle, exposure to toxins, and even stress levels can all impact how our genes behave. So, this complexity adds a layer of difficulty in accurately predicting how an individual will respond to a particular drug based solely on their genetic makeup. So it's hard to kind of purely isolate the gene and say, okay, based on this blueprint, this is what's going to happen. There's so much more involved. In addition, it's important to note that only like about 10% of our genes are directly influenced by biomarkers and drug response. Only 10%. So this means that the majority of our genetic code may not even be directly related to how we metabolize or respond to medications. So that's another key complexity that we want to highlight, and the need for comprehensive and nuanced approaches to really understanding pharmacogenomics. Moreover, drug response genotypes are not solely determined by genetic makeup, unfortunately. Like we said, there's so many other factors involved in your body, in the patient's body. We talked about when it comes to infectious diseases. We are also thinking about the viroid DNA itself. And what's scary about infectious diseases, and like research had noted, resistance is really happening, or the ability for them to resist these drugs when it comes to infectious diseases is because a lot of these microbes and viruses are changing their own DNA to adapt to our medications. How scary is that, right? So they're working and seems to be more adaptive than we are when it comes to our sciences, these viruses and microbes. So again, this is something that we need to be aware of. Hope, absolutely. We can definitely challenge this and overcome all these challenges. It's just a matter of being aware of them. So current trends, it's just in general, we talked about earlier, I brushed up a little bit about the technology. Next generation sequencing technology is huge when it comes to advancing pharmacogenomics. The problem is it's not commonly used for all your chronic conditions. So it's the idea of trying to better integrate them in our healthcare system. Machine learning algorithms, our AI, are being developed to interpret complex genetic data. And then the increasing focus on rare genetic variants influencing drug response. We talked earlier about biomarkers. They're being integrated into electronic health records. So there's definitely been movement. It's about kind of pushing it even further, right? Building that momentum for more advancement in pharmacogenomics. We have point of care genetic testing that's becoming more accessible in clinical settings. And even large scale biobanks. They're actively facilitating population level pharmacogenetic studies to push the needle forward in this area. Ethical considerations, like any innovation or any new treatment therapy, we need to worry about a few things. So, while pharmacogenomics offers unprecedented opportunities to tailor treatments to individual genetic profiles, it also raises some questions that we need to address. One of them is the issue, of course, like any other condition of informed consent and patient autonomy. We need to make sure we have that in place anytime we provide genetic testing. So the patient really needs to understand the implications of genetic testing. That includes the potential risks that are involved, the benefits, and the limitations. So the providers have a responsibility to ensure that patients are fully informed and empowered to make decisions about genetic testing and what they can do and how they can use this information in their treatment plan. Another key ethical consideration is the protection of patient privacy and confidentiality of genetic information. Think about it. Genetic data, it's highly sensitive. It could reveal intimate details about an individual's health, ancestry, even potential future risks. It's imperative that we have robust safeguards are in place to protect the patient's data, ensure confidentiality, and prevent unauthorized access or misuse of this information. In addition, there are concerns regarding potential genetic discrimination. What if employers, insurers, or any other third party end up misusing this genetic information to make discriminatory decisions related to employment, insurance coverage, or access to healthcare services? So again, safeguards need to be implemented to prevent this from happening and ensure protection of individuals from unfairly being disadvantaged based on their genetic makeup. So these are all things we need to keep in mind. Lastly, when it comes to genetic testing, this is a big deal. Another key challenge is regarding equitable access and affordability of pharmacogenetic testing and treatments. So disparities in access to genetic testing and personalized medicine could exacerbate already existing health inequities, specifically in underserved populations. So efforts need to be made to make sure that pharmacogenomic technologies are accessible to all patients, regardless of their socioeconomic status or the geographic location. Okay, almost done, guys. A little bit about regulatory. I definitely can say there has been movement done in this area, whether it's the FDA or the EMA, who have been recommending pharmacogenomic test studies and developing frameworks for pharmacogenomic test validation. So regulations are evolving to address this direct to consumer genetic testing concerns, and they are working to balance innovation with patient safety. The goal is, of course, through regulatory advancements that'll help us further drive innovation and foster collaboration among stakeholders because with proper frameworks, we can foster a collaborative environment that promotes the sharing of knowledge, data, and best practices, ultimately to accelerate the pace of discovery and translation into clinical application. The legal implications of this. Well, of course, just like regulatory, they are still developing legal frameworks and trying to address as many of the issues relating to this type of tests and applications. The goal, again, like we discussed, key elements, protecting genetic privacy, preventing discrimination. They're all key factors that discipline is be focusing on. There is, of course, still a need for very clear guidelines on legal obligations. There's a lot of talk, there's a lot of writing and research that's been done. To tell you the truth, there's still more that's needed because there is that potential for legal precedents when it comes to malpractice cases. It's a matter of, did you tell us enough information? Did you tell us not enough information? So those are all things and questions that need to be addressed by the legal team. Challenges include, of course, keeping legislation current with the rapidly advancing technologies too, right? We talked about a few, the microarray technologies and all this AI that's coming in. How do we make sure we are on point and up to par with those? And of course, issues of liability always arise in cases of adverse events with available genetic information. What do we do in those cases? What do we do when there's a mistake that takes place? Awesome. So, economic impact of pharmacogenomics. A few things about economic impact. Now, it depends on your region. That's why I'm so happy we have a global audience. This is going to be quite interesting to hear your comments. But just in general, the first thing that you think about is the issue of reimbursement policies. Now, as personalized medicine, it becomes more prevalent. Payers, healthcare systems are faced with that challenge of determining how do we reimburse this to make it standard of practice, right? And then, and also in a way where it allows everyone from all socioeconomic status to have access to these tests. So, really, our number one key element to improve pharmacogenomics is realigning those reimbursement policies with principles of value based healthcare. Payers can then incentivize the adoption of pharmacogenomics by rewarding interventions that demonstrate improved outcomes and cost effectiveness. So, this shift towards value based reimbursement models really encourages providers to integrate PGX data into clinical decision making, leading to more efficient and personalized care for patients. In addition, you may think of it, upfront costs are pretty high when it comes to genetic testing, right? And personalized treatments. We all know you're adding more dollars when you ask or request these specific tests. But the idea is with further awareness and education that we truly show the significance of PGX because it can truly lead to long term cost savings by reducing adverse drug reactions, hospitalizations, and ineffective treatments. So if you want to look at the short term, yes, I understand there's more costs involved, but we want them to start being more aware of the long term effects of this PGX texting. So what's the story with global health? There's so much we could do on a global scale because there's so much variances and differences in different populations and subpopulations. Can you imagine how much we can study and analyze when we look through at different geographies and different populations and understand and to better understand how the genetic variances are impacting their responses to medications or potential adverse events. So it's crucial for us to help optimize drug therapy in a resource limited setting to start really focusing and thinking about PGX on a global scale. It's about time for us to start really collaborating as stakeholders to create these large scale projects to come up with, to advance or accelerate research and hopefully improve health outcomes in all countries, including developing countries. Education and training, of course, that's critical because people need to understand the benefits of these tests and despite maybe potential inconveniences in the beginning. Honestly, based on the research, there is showing a growing need for education in the curriculum to be integrating, whether it's in the curriculum or continuing education programs to be developed for practicing clinicians. Challenges, of course, include rapidly evolving fields, right? And the changes in the technology. So we want to make sure that we stay up to par with that and make sure our education is up to par with the changes that are taking place. Providers really should be required to go through trainings to better interpret and apply the genetic information that is provided to them by these genetic labs. Patient education is crucial because we want these patients to feel empowered. We want them to feel that they are informed in the decision making process during the pharmacogenomic testing. And lastly, pharmacogenomics really needs an interdisciplinary approach. There's so much that could be done with pharmacogenomics in all disciplines, including the social sciences, when it comes to understanding behavior on a population level and group dynamics. So we'll move on to the last but not least, some key strategies. So what are a few things that we can start talking about or we can start doing to accelerate the pharmacogenomic implementation? One, of course, start requiring multidisciplinary collaboration in healthcare systems, creating an environment that we encourage and promote collaboration, right? Trying to continuously encourage and integrating these clinical decision support tools within the EMR system to aid them with prescribing on a daily basis. Preemptive testing strategies are being explored, of course, for efficient implementation. And then standardization is huge of reporting and interpretation of the results. So everyone can, all the healthcare providers can use it for all chronic conditions. Now, challenges, of course, like any other situation, in new diagnostic treatments is the integration into the clinical workflow. So it becomes a part of their daily routine and doesn't feel like a burden for these providers. And there is a need for ongoing evaluation, of course, and quality improvements in implementation. That's always critical. Drug safety monitoring is a huge element of pharmacogenomics because when we use that, it enhances the post-marketing surveillance of drug safety. Genetic biomarkers help identify subpopulations that are at risk, like we discussed earlier, when it comes to rare conditions or adverse events. And it's aiding in understanding the mechanisms of these drug interactions. So again, like all the other benefits of pharmacogenomics, drug safety is a number one on the list and a key priority. And they have been making some moves when it comes to including pharmacogenomic information in drug labels and warnings. So that's exciting. Challenges, of course, include detecting and validating genetic associations when it comes to rare events. So there's a lot of opportunity here for this area to grow even further and integrating it into the common resources and the drug labeling to help in making everyone more aware of the implications of pharmacogenomics. Another key element, hopefully, that we hope to move forward with is the clinical guidelines. There has been some guidelines, of course, when it comes to pharmacogenomics, but there's so much more that can be done and developed. And it really is critical because guidelines serve as a roadmap for healthcare providers. It outlines best practices, recommendations for incorporating genomic information into patient care. So when we put effort and energy into further developing the guidelines that we have, it helps standardize the practice. It promotes consistency in decision making, and it really ensures that patients receive the most appropriate and effective treatments. So, the key element or aspect of developing guidelines is establishing, of course, evidence based recommendations. And it really, like we all know how the process goes, that involves gathering and evaluating high quality scientific evidence to support the inclusion of testing. So that, of course, that's going to require rigorous research, systemic reviews, meta-analysis, all of that. All we're trying to say is that we know that's been established already, but there's so much more that we need to do to be up to par with the science when it comes to science guidelines that really truly address practical considerations such as test selection, interpretation of results, and implementation strategies. So again, providers not only need education, they really need us to provide them with a clear and concise guidance on how to use these steps. And that should include a step by step instruction and actionable recommendations to make it practical for them to streamline it and adopt it in their clinical settings. And then precision public health, one of my favorite topics, and the future of pharmacogenomics. The idea is through epidemiological research and population level studies that we can truly start tailoring these large chronic conditions that have been, overwhelming our societies for so long through pharmacogenomics. The idea is that we can contribute to the understanding of the population drug response variability better when we do these large scale public health research studies. Applications include optimizing national formularies, vaccination programs, and it really does include balancing individual and population level benefits when we take that little lens of precision public health when it comes to pharmacogenomics. Okay, and then when it comes to the patients, most importantly, perspectives, we need to keep in mind again that while we're planning and implementing pharmacogenomics, don't forget the patients. This is what we are, who we are serving and who we're trying to benefit. There is a need again for patient education materials. Patient advocacy groups play a crucial role in promoting pharmacogenomic research. So we need to kind of find a way to always work with them to promote pharmacogenomics. And then patient understanding of genetic risk. They need to really believe that there is a risk for them to come in and actively be involved in pharmacogenomic testing with their providers. And then last but not least, pharmacogenomics, the future, is poised to revolutionize drug therapy and patient care. The goal is for us to integrate it into clinical practice uh, and to help it grow despite the challenges that we talked about earlier. So again, we want to continue research, technological advances. We want to make sure, though, of course, that the ethical, legal, and social implications are fully understood so we can provide the guidance that's needed to avoid any of issues to come about from such a large scale project. So again, the ultimate goal is our patients. They remain to be our number one priority and to improve the patient outcomes through these personalized medicine. Okay. And that's all I have. We will have the slides, in I believe, in the library for APGX for you to look at. We have a ton of references. You're welcome to review and on your own time at your leisure. Any questions at all?
Wow, wow, wow. Fantastic, fantastic.
Thank
You
you.
would all agree with me that the session has been very awesome. Has been very awesome. Thank you so much. Thank you so much. I've gained a lot, and I know that everyone on this call would have learned a lot. Thank you so much. So we'll be
You're
going.
so welcome.
Please, Sir Abdul Karim, please, can you mute yourself? Mr. Abdul Karim, please. Thank you. So we'll be going straight to the Q&A session now. We'll be taking the questions. I think we'll just start with the questions we have in the chat box,
Hello.
so we can start from there. Yeah, please, can you mute yourself, please, Mr. Abdul Karim? Okay, okay, okay. So we'll take the Q&A now. I'll just go to the chat box to see which questions we have waiting for us there. Okay, I think I see one here. Wow, really long questions. Um, okay, okay. I think the first one is about. Um, can we hear me, please? Okay, I think the first question is from Gina. Gina is
Yes, we
asking.
can.
Gina is asking to know if, or he's asking how common PGS texting is for HIV currently. How common PGS texting is for HIV currently. Would you want me to take all of the questions before answering, or we just take them one after the other, Dr. Luma? Can you hear me, Dr. Luma? Would you want me to take all of the questions first, or we'll just take one after another? Okay.
Okay, sorry, I was muted, Destiny. No, we can go one at a time, or we can go through different topics.
Okay,
I know
fantastic.
there's a few that are unmuted. We'll try to work through this.
Okay, okay. Yeah.
So yes, that was a great question regarding HIV specifically and how commonly it's used. So a little bit about the stats when it comes to pharmacogenomic and HIV. It is prevalent because the back of the issue with life-threatening conditions. I know at least in the U.S. They required in most
Sir Destiny,
facilities.
can you mute, please?
I'm sorry, can you hear me? Or? So I can tell you from like the Mayo Clinic, it had a study recently in the journal AIDS 90s affect response to drugs in pharmacogenes in order to predict their risk toxicity. That was just the number at their specific site. We just the recent study that took place. This was in June 2023 at the Mayo Clinic. That's of course in the U.S. And an international level. I'd have to look into it. I'll be happy to provide those details after. But in general, between 2018 and 2020, the HIV specialty clinics had consented to an escalated amount. Most participants, they said about 89%, were involved. And so I'll provide you if you'd like, if you want specific stats, I'll be happy to provide those specifics after our call today. I'll make sure to send an email with responding to these questions. Destiny, would you
Fantastic.
like to go on to the next question?
Fantastic. Yes, I'll take the next question now. Um, okay, I think could you repeat the name of the technology? Okay, someone asked if you could repeat the name of the technology used to analyze the thousands of compounds. The name of the technology
Oh,
used to
sure.
analyze
Those
thousands of
are referred to as microarray technology, MICROARRAY. Those are new technologies that are being implemented to help providers see things on a very large scale. So they're called microarray technologies.
Okay, fantastic. I'll take the next question now. Um, okay, that's from Gina. Sorry. How standard is PGS texting for HIV currently? Okay, I think that has been taken. Um,
Yeah, sorry, I asked the question again.
okay,
I asked the question earlier.
okay. How standard is PGS texting for HIV currently? Would it be specific to HIV only, or would it cover the disease as well? That's the first question. Dr. Gina. Dr. Luma, please, you take that one.
Sure, absolutely. I'll be happy to explain a little bit about how it's being used in the HIV. As I said, based on the Mayo Clinic recent study, in their HIV specialty clinic, they did say about 10% of treatments have been modified based on HIV or PGX testing. They did manipulate a little bit of the medications that they were being used. As of yet, the most common one that's being used for HIV is abacavir. It is not being used as prevalently as we'd wish, just because one, research, and two, Abacavir is a life-threatening condition. So definitely, I can tell you, it's more about the medication more than the disease. And I wish it was different. I wish they had more advancements when it comes to pharmacogenomics in general when it comes to the disease itself.
Okay, great, great. I think this number two is a continuation of that first question. How expensive is it to order, and could insurance cover it? That's the next question.
Sure. So it does depend on the country. Is this from the U.S. a question, or is this from outside of the U.S.?
It's from outside the US. I'm just thinking of like, would insurance affect the goal of and for pharmacogenomics to be equal for everyone?
That's a fantastic question, a very big concern. Since the history of the beginning of pharmacogenomics, they have noticed that the insurance coverage of pharmacogenomics has improved the patient's, access to the testing. So a lot of people, as you know, are not going to pay $600, $700. That's what when it first started. They were paying $600, $700 for these testing. The great news is that insurance, at least in the U.S., has been covering a great portion of the genomic testing. Another key element when it comes to pharmacogenomics is that insurance sometimes covers a portion, a sequence. It doesn't cover you have the entire genome. So those are all questions that need to be thought about as challenges for the progress of pharmacogenomics, because absolutely patients, unfortunately, no matter how much they want to do pharmacogenomics or how cool it sounds to them, or at the end of the day, people sometimes are living paycheck to paycheck. So is it their food or is their genomic testing? So um, the more we're able to create opportunities for insurance coverage for these types of testings, or like I mentioned earlier, incentivize them for providers to incorporate that, the more likely patients, or more practical, really, patients will be using it.
All right, great, great. I think the next question, I don't know if it's been answered already, but I'll just take it now, if it hasn't been. Would insurance coverage impact the test's goal of equity? That's the next question.
Yes, so that's another big concern too, is that if you have a high salary with the private insurance versus if you have, at least in the U.S., Medicaid or Medicare, state insurance, and each one is different when it comes to coverage. How fair is that? So the idea is that, or at least what we're encouraging is that it become across the board, that everyone with insurance or regular private insurance or state insurance to have the same coverage when it comes to genomic testing, because that will affect, like you said, accessibility and fairness.
Great, great. The next question, if you get tested once, do you need to be tested again?
Great question. It does depend on the type of testing. So there are specific tests that are done, for example, in cancer patients, that are, or other conditions like mental health conditions that are looking for specific genes in the sequence. So the provider may request a specific gene sequence to be reviewed. Now, if you do a full genome, which doesn't happen because it's very expensive, through the next sequence genomic panel, then of course you don't need to do it all the time. Now, there are, of course, some visionaries in the field that really want us to integrate genomics, that it becomes profitable for or cost effective. So they do have it done on a frequent basis, at least on a yearly basis, to incorporate or also encompass the like the environmental changes. So I'm going to give you an example. Some pharmacists, for example, were telling me how like smoking changes the patient's genetic composition, one example, right? Or their stress, like we talked about, all these environmental factors that are changing the gene composition. So they were advocating that if we can have more genetic testing done, if it's cost effective, of course, then we can start noticing these genetic variances over time, if we actually kind of follow through with them. Because again, like in the environment itself changes, and that automatically there's an interplay in affecting their genes. Besides the fact that many providers ask for specific gene sequencing done if they are diagnosed with a specific chronic condition. So, in the case of, for example, I gave an example of mental health, psychology, the antipsychotic drugs impact specific enzymes and specific genes. Same thing with even asthma, too, like the bronchoconstrictions, like your basic albuterol or your inhaled corticosteroids that are used very commonly. They have different, each individual has a different response to these medications, and it affects different genes. So a lot of times providers may ask for additional gene testing if they are diagnosed with a new condition. But again, like I said, a lot of people want even more genetic testing done to factor in those environmental changes that take place that may impact their gene composition. I hope that
Great,
answers the question.
great, great. And the last question here from Gina is Is PGS texting more accurate in detecting potential diseases than a more specific test, such as the BRCA test? Yeah, you got that?
I'm sorry, the other test was ROC test?
BRCA test.
I didn't hear. BROC test?
BRCA
Oh, got it.
test.
Got it. Okay, thank you. Great question. So yes,
Hello,
it's of course it's not solely by itself, right? So pharmacogenomic testing analyzes how the genetic makeup
Wala.
affects the response to medications. So when you use the PGX testing, it can be used to predict how an individual will respond to the medication. That's specifically pharmacogenomics. Now, the BRCA testing is a genetic test that identifies mutations in the BRCA1 and BRCA2 gene, which are associated with an increased risk of breast and ovarian cancer. I hope that's the test that you're referring to. So the BRCA testing is used really to assess a person's risk of developing that specific condition. When we talk about pharmacogenomics in general, we're talking about a test that covers multiple genetic gene codings. So it's not just the BRCA test. So that's why, for example, like you said, those are very effective and just as effective. It's really a matter of, are you both coming in to do a test to worry about one specific gene that is affiliated with breast and ovarian cancer, or the other example is the test that's commonly used in Alzheimer's, the APOE, that's commonly associated with changes in response to the medications provided in Alzheimer's. They may ask for just an APOE gene. Those are all under the umbrella of genetic testing. Pharmacogenetic testing usually is much more comprehensive and encompasses much more genes. That's really the difference between the different types of tests. I hope that answers the question.
Thank you so much for answering all my questions.
Of course.
Great, great. So we'll go to the next question now. I think that's from Daniela. She wants you to reiterate. I think she said reiterate on warfarin and abacavir. I think she wants you to say some things about.
Absolutely.
Yeah, yeah. Thank you.
Sure. So we can definitely review warfarin really quickly, and then we can talk about abacavir. Warfarin was focusing the cardiovascular conditions, and like we discussed earlier, there are two key enzymes when it comes to warfarin. Now, I'm not sure if this is a medical student or a provider, but I'll briskly review the mechanism of action of warfarin to help you understand how it's essential or significant, the pharmacogenomics. So again, when it comes to warfarin, I'm not sure if you remember the VKORC1 enzyme. I hope that rings a bell, but that is pretty much involved in the vitamin K metabolism. As you know, warfarin, its standard mechanism is blocking or as a vitamin K antagonist, right? So um, when it's so the key enzyme is VKORC1. The other key enzyme when it comes to warfarin is the cytochrome P2C9. Now that is relating to the metabolism of warfarin. So here's the deal. When the metabolism, so the cytochrome P2C9 gene, is different in each patient, so the individuals removing it from their body at different rates, that leads to variation of the drug levels in the body. So this can affect the therapeutic response of the warfarin to warfarin. So some patients may require lower doses to slow because due to their slower metabolism of the drug, and others may need higher doses for optimal anticoagulation. So that's the 2C9 gene and how it's affecting it's because it impacts the metabolism of warfarin. And if you have a variant on that gene code, that will impact how long warfarin stays in your body. So if you can imagine, again, dosing and when it comes to frequency of the drug is all kind of studied from a pharmacodynamic and pharmacokinetic perspective. That's how they make those decisions as to what's safe. So if you can imagine warfarin, all drugs have some type of toxic side effects, right? If it stays too long in the body, what that could do to you, that could be toxic and increases the risk of bleeding. Versus if it comes, or and the vice versa is the opposite. If it gets metabolized really quickly and gets cleared out of your body really quickly, then what's going to happen, right? It's not going to be effective. You don't have enough drug staying in your body for a long enough time to actually do its effect, right? To actually have an impact and change your condition. So that's for the 2C9 metabolism. I hope that made sense for the VKORC1. Again, that's inhibiting the activity because, in general, the mechanism of action of warfarin is that it directly inhibits the activity of that enzyme, the vitamin K epoxide reductase, which is essential for the synthesis of clotting factors in the liver. So by interfering with the production of these clotting factors, by hitting or targeting that specific enzyme, that's how warfarin helps to prevent the formation of harmful blood clots. So if we have a variant on that gene that expresses the VKORC1 enzyme in different people, that means then when you provide them that drug, the warfarin, which is an anti-V, it's intended to inhibit that enzyme, you're going to have to make sure that it's not too high, not too low. It needs to be tailored based on the variant, genetic variant that that patient may have that impacts how fast or how slow that enzyme is breaking down that specific vitamin K. So I hope that makes sense how it's all kind of connected when it comes to anticoagulation and bleeding with warfarin. I hope I didn't confuse you.
Okay, that's great. I think the next question here is from Abu Bakar. He wants to know the role of pharmacogenomics in the management of diabetes.
Fantastic. Okay. So yes, absolutely. That's a very good point. There has been some updates and changes when it comes to pharmacogenomics. I can tell you when it comes to some very common medications like your metformin, there is a new genetic variation called the SLC22A1 gene that has been associated with differences in metformin response and risk of side effects. So the goal is that through the testing of pharmacogenomics, it can help identify who's going to be more sensitive to metformin or at higher risk of developing side effects. Another key drug in the diabetes is your sulfonylureas. They have been associated with the cytochrome P2C9 and the VKORC1 gene. So genetic variances in the 2C9 and VKORC1 gene have been linked to variations in how patients respond to sulfonylurea, which is a class of oral diabetes medications. So if individuals have variations in their genetic profile, that's going to require either to lower or higher the doses of sulfonylureas to achieve optimal blood sugar control. So those are two examples when it comes to diabetes medication management.
Fantastic, fantastic. I would go straight to the next question, and this is from Abiyeye. Rukiat. He said, please, can you help expatiate on the role of pharmacogenomics in Parkinsonism? I think that's what it means. And also that,
In sorry, in Parkinsonism?
yeah, pharmacogenomics and Parkinsonism. And Alzheimer's was mentioned also in relation to memory, the connections between those.
Sure. Absolutely. Okay. So when it comes to Parkinson, those are great questions. There has been some progress as well. The drug response variations can influence, again, how the patient responds to medications commonly used in this disease. So, for example, your levodopa, your dopamine agonists, and your MAO inhibitors, those common medications used, can be, each patient has a different response to them. So, the testing, it helps identify genetic factors that affect the drug metabolism, efficacy, and the side effects. So I'm going to kind of go into detail about like or specific examples of levodopa. I'll use that one. So levodopa metabolism, it's a primary treatment, like I discussed, and its metabolized and metabolism can be influenced by genetic variations in enzymes such as the COMT, catechol O methyltransferase, and DDC, dopa decarboxylase. So there are very two significant enzymes that influence the metabolism of levodopa in the body. So pharmacogenetic testing can help predict how individuals may respond to levodopa and guide their dosing adjustments based on any genetic variations in those enzyme expressions of, again, COMT and DDC. Now, dopamine receptor genes. So they also, research has noted genetic variations in dopamine receptor genes like DRD2 and DRD3. Those are very common in Parkinson's, and they may impact the response of the patient to dopamine agonist medications when they are used in this disease. So when you do the testing, it really helps providers identify individuals who have a better or poorer response to these specific dopamine agonists. Now, of course, risk of side effects. When you do know that this patient has that genetic variation, you're more likely to help or help avoid patients from taking either too much or too little of the medication. So you can adjust the dose, or you can consider an alternative medication based on what you know from these pharmacogenomic testing. It really does allow for a proactive monitoring and dose adjustment process. So that's for Parkinson's. Now, when it comes to Alzheimer's disease, you want to keep in mind a few things. And I talked a little bit about that. Two key elements when it comes to Alzheimer's and how it's impacted is one, patients that have the APOE gene in general have a higher risk of developing Alzheimer's. So this is huge when it comes to patients that don't even have Alzheimer's disease, right? So they are not even diagnosed yet. They may be in their 30s, in their 40s, and maybe they have a family member that has Alzheimer's. So by them being proactive and completing a pharmacogenomic test to see if they have that APO gene, that will help them kind of be more proactive in, or preparing better for Alzheimer's disease and working with their doctor to see if there are any signs and symptoms that come up early on in the phase of the disease. That's one piece. The other piece is the specific drugs when it comes to Alzheimer's, like I talked about two of them, the NMDA receptor antagonists like memantine, or the cholinesterase inhibitors like donepezil, rivastigmine, galantamine. Those are two major medication classes used to treat Alzheimer's disease. When you do PGX, you can determine how well the patient responds to the medications and also how well they metabolize or how fast they metabolize them. That will help you either increase the dose or decrease the dose to avoid additional risks of adverse reactions or to improve patient outcomes, right? Because if you are metabolize like warfarin, if you metabolize the drug too fast, right, and it flushes out of your system too quickly, it's not going to have enough time to do what it needs to do in your body, right? So because of that, when you know how it can affect the metabolism, that will help you predict how the individual will respond. And hopefully, as a provider, you could optimize therapeutic outcomes and minimize side effects with that information. I hope that answers the question. So again, when it comes to Alzheimer's, we talked about levodopa and dopamine pathways. When it comes to Parkinson's, When it comes to Alzheimer's, I want you to think about APOE gene. That is the most well-known genetic risk factor for late onset Alzheimer's disease. So particularly, they all when you talk about that gene, it's the E4 allele that is associated with increased risk of developing Alzheimer's. So like any other condition, the earlier you know your risk of a condition, the more likely you'll be able to manage it or treat it like cancer or any other condition. If you can't treat it, at least better manage it. So I hope that answers that question.
Great, great. I'll take the next question now. Um, can pharmacogenomics be done in silico, as in virtual simulations? That's from Suleiman.
Could you repeat the question? I couldn't hear you. I'm so sorry.
Can pharmacogenomics be done in silico, as in virtual simulations?
Oh, very interesting. Um, so that's a very good question because that brings up a new uh, innovation that they have been studying when it comes to in you mean in virtual, like you're referring to like AI like that, or could you clarify what you're asking? I answered correctly.
Yeah, Suleiman, are you on the call, please?
I yes, thank you very much. I mean, something similar to chemoinformatics and bioinformatics, where you have ligand and protein interactions, where you just simulate it before you now take it in vitro, so to say.
Okay, so I heard you said bioinformatics in vitro and how like is there a way for us to study the different changes like the gene and the protein? Is that correct? In interplay, is that
Yes,
what you're
what I
asking?
meant
Yeah.
is whether pharmacogenomics can also be done in silico as it is being done in bioinformatics during protein ligand interactions. Is there facilities available for studying pharmacogenomics in silico?
So okay. I'm taking notes here. So that makes sense. Thank you so much for that clarification. Great point. Yes. So I'm going to tell you honestly, I am not aware of any major institutions that have been studying pharmacogenomics. I have heard though, I am very familiar with your, like you said, the pharmacoinformatics and bioinformatics, where they do study the changes over time, the fluid changes, the protein dynamics, all that interplay. That's definitely there. And because of that, they were able to come up with those new drug discoveries in cancer that are focusing on like the histone deacetylase, like I said, inhibitors. Those are key examples of how it did involve pharmacogenomics. So they studied how the drug itself, the histone deacetylase inhibitors are epigenes. And these are epigenetic modifiers that come in and they come in and impact or influence that specific gene. And they have been able to, over time, see how that has impacted or influenced protein expression because histones, as you know, is a type of protein. So definitely, I can tell you, I am not aware of specific names. I've worked myself with a few medical engineers from different, in general, when it comes to research, but I'm not aware of any institution. I can definitely ask for you that are actively involved right now in studying actively the different interactions on, like you said, the bioinformatics and in silico, like so you can actually see the changes. So I can definitely ask and get back to you on that one.
All right. Um, all right. Thank you so much. I think I see some very similar questions here, so I think I will just take one of them so as to save our time. Um, there is one about um, what are the practical ways to integrate pharmacogenomics into routine clinical practice in developing countries like Nigeria?
Great question. I don't think I would be like the best person to answer that. I can tell you from